And I want to thank staff for their hard work, okay, and for the food and everything you're doing for us. Let me know when we're live. We are? Beautiful. So good afternoon, everyone. Those of you that are watching us at home, thank you for being with us. This is the Health and Government Operations Committee, and my name is Jocelyn Peña-Melnick, and I'm joined by my wonderful Vice Chair, Delegate Bonnie Collison. To my right, I have the amazing Lisa Simpson, who is our legal counsel for these the subject matters that we're going to be discussing today. So this is our first week of briefing. We had one yesterday. Today's our second one, and today we also have our first bill hearings for this session of 2025. I kindly ask for your patience if we encounter any technical streaming issues. Sometimes it happens, and trust me, we will do our best to fix it. This briefing is being streamed on the Maryland General Assembly YouTube channel. Before this briefing, all members were emailed a copy of each presentation. If you don't have these documents, please let the committee staff know. Andrea, we'll be able to, she's listening, be able to get it for you. Please adhere to our usual committee rules of one question and one answer from the panel. Keep your questions brief. We can also ask questions offline. And I forgot yesterday, can you please turn your phone off unless you need it to have it on for an alarm? You can do that, okay? There's no judgment. Please keep in mind that I plan to conclude by 2:30 because we have bill hearings afterwards. So today the House and Health and Government Operations Committee will hear a presentation on the Prescription Drug Affordability Board. And we will begin with Andrew York, who's the Executive Director of the Prescription Drug Affordability Board. Mr. York, please begin your presentation. And good afternoon.
Vice Chair Collison and members of the committee, thanks so much for the opportunity to speak to you today. My name is Andy York, and I'm the Executive Director of the Maryland Prescription Drug Affordability Board. We wanted to provide just a quick update on our work. We've presented to you in the years past and always had the honor of talking to you about our work, but we're excited to have a pretty busy and exciting year ahead of us. So we wanted to give an overview of the Prescription Drug Affordability Board itself for any members that may be unfamiliar with our work. We wanted to provide an update on our cost review study process. We also wanted to provide an update on our policy review process and upper payment limits. And then also we've received questions about the expansion of Prescription Drug Affordability Board authority. Yes. Thank you. Great. Is that better? Yes. Great. Okay. So just for everyone's reference, the Maryland Prescription Drug Affordability Board was created in 2019, and we are the first in the nation Prescription Drug Affordability Board, though there are probably about 4 other states that have followed in Maryland's footsteps. It's led by a 5-member board supported by a 26-member stakeholder council, and the stakeholder council is supposed to represent the different sectors within the prescription drug supply chain. So we do have really great support and input from everyone that is affected by our work. And the purpose of the board in our statute, and I always like to read this language specifically, is to protect state residents, state and local governments, commercial health plans, healthcare providers, pharmacies licensed in the state, and other stakeholders within the healthcare system from the high costs of prescription drug products. And that's ultimately the mission that the board refers back to whenever we're doing our work. The 5-member board is made up of different appointees. They're appointed from different offices. We have our chair, Van Mitchell, previous legislator and health secretary, appointed by the Senate, President of the Senate and the Speaker of the House. We have then 3 health sciences researchers, Dr. Joe Levy and Jerry Anderson, appointed out of Johns Hopkins University. Dr. Anderson's appointed by the Attorney General. Dr. Levy is appointed by the Office of the Governor. Dr. Barry Nukuga is out of the University of Maryland School of Pharmacy, and she is appointed by the Speaker of the House. And then finally, our physician, Dr. Stephen Rockhauer, was appointed by the President of the Senate. And I'd just like to go through their resumes and their backgrounds just to show that this board has a lot of experience in the space and are experts within their own rights and accomplishments. So there's 3 kind of high-level pieces of work that our board does. The first thing that our statute outlines is something called our cost review study process. And this is basically an in-depth review of specific drugs to understand if they cause affordability challenges. And if you remember any of our briefings from previous years, one of the key issues in the prescription drug space, though I think this is representative of healthcare as a whole, is that policymakers such as yourself and the board, we see what is called kind of the gross spend, the high-level spend of prescription drugs. But then there's what are often kind of off-invoice back-end rebates that get the drug to a lower net cost. So the ultimate debate that you'll hear from different folks in the prescription drug supply chain is saying, oh, look how expensive prescription drugs are. And then other folks will say, actually, they're not that expensive. You just can't see how cheap they are because of these rebates that we can't tell you about, right? So ultimately, the idea behind these cost reviews is to allow us to do an in-depth review and try to get access to some of this confidential proprietary information so we can actually understand if patients in the healthcare system are having trouble affording their drugs. I'll go over that process in a little bit more depth in just a moment. We also, the statute created the authority to do something called setting upper payment limits. And this is ultimately a policy tool, a very specific tool in the toolbox of the board to address affordability challenges that we identify in the cost review process. We drafted something that I'll mention in just a moment called our upper payment limit action plan, which basically explained how the upper payment limits would work. I'll give you an update on that status, but that was approved, so we're now working on taking the steps necessary to actually use the different policy tools available, including setting upper payment limits. And then ultimately, we also want to be a resource to legislators and other policymakers on all of these complex issues in prescription drug pricing. So we do want to be a resource available, and we put out an annual report that may have deep dives on specific issues, and we can make different policy recommendations to our executive branch partners as well as our legislative partners. So just as a brief timeline, I mentioned we were created in 2019. Our first 2 years in 20 and 2021 were kind of a lot of the infrastructure related, it was setting up a lot of the infrastructure and processes that come with standing up a new agency. We also needed to get our funding established. So there was a bill in 2020 that was passed that created our funding process. We're funded through an independent, it's a special fund that is funded through a fee assessment on all of our regulated entities, wholesalers, pharmacy benefit managers, health insurers, and manufacturers. And that bill was vetoed, so then in 2021, that veto was overridden. So a lot of our work really started in 2022. And the first thing we did was created our supply chain report. So that was a long-term process, and I'll go over that in just a moment. And then we also had to develop the processes and regulations to do our work around the cost review study process, and then also our policy review process, which is how we would go about setting up our payment limits. So a lot of that was what we worked on through 23 and 24. And now all those processes are set up, and we're very excited to continue doing a lot of that work through 2025. So again, just an update on our supply chain report. It's about a 120-page document that is basically supposed to be a handbook on all the different issues you may face related to prescription drug pricing. The first half of the report kind of identifies different market failures and issues that we see in the prescription drug space that may make drugs unaffordable. And then the second half is the different policies that are available to the state, usually through legislative action, to address those different policy challenges. So we do want that to be a handbook for you. We tried to make it as user-friendly as possible, but that is kind of an ultimate reference that we did want to make available to different policymakers. I'd say the key takeaways are that it's an extremely complex supply chain, and there's different market failures in different circumstances. So there's different reasons a drug may be affordable that have different policy solutions for each of those issues. Also, there's a number of different drivers that cause affordability challenges for patients in the healthcare system, and often those can be two different issues. A drug can be unaffordable for a patient, well affordable to the healthcare system, and vice versa. May be perfectly reasonable to the healthcare system as a whole, but may be difficult for patients to afford. And then there's, again, a number of different policies available for states to address different market failures, and I would expect this kind of legislation to come before this committee even as soon as this session. So there are a number of different things that states can do, and we're always here to help kind of work through some of the complexities of some of those policies. Next, I wanted to go into our cost review study process. So again, we passed regulations to actually establish the process that I had mentioned. And it's basically a kind of a five-step process. The first thing we need to do is the statute and some supporting regulations that we created create a list of drugs that are eligible for the cost review study process. And it's a pretty substantial list. I think about 2,000 national drug code products. So that you can have multiple NDCs for one product. So it's not necessarily 2,000 products, but it is a substantial list of drugs, and it's a subset that the policymakers and the board are actually concerned about. So the first thing we do is identify all of the eligible drugs, and then we go through a selection process, and I'll move over to the next slide, where the board kind of identifies the drugs that they are most interested in and refers them to our stakeholder council, which is our group of subject matter experts, to get input on some of the ones that the board is interested in. Then, based on the feedback from the stakeholder council, the board ultimately selects drugs to actually go into the cost review study process. Once it goes into the cost review study process, we get to try to collect a lot of that additional information that I had mentioned earlier. We have something called our request for information, where we reach out to different stakeholders and ask them to provide information that can help us make this ultimate determination of if a drug causes affordability challenges. Once that information is collected, the staff then analyzes that data and puts together a series of summaries and analyses. We call it informally our dossier that goes before the board. And then the board ultimately makes the determination of if the drug causes an affordability challenge. That's the process at a very high level. Our board has selected 6 drugs for the cost review study process. They selected these drugs, I believe, in May of last year, so you can see what a deliberative and kind of long-term process this is. We've done our request for information for the first 4 drugs, Farxiga, Jardiance, Ozempic, and Trulicity, and we'll do a separate request for information on Dupixent and Skyrizi. And then right now we're in the process of the analyzing of that data, and that data will be brought to the board for them to make their preliminary determination of if the drug causes affordability challenges. So we're right in the heart of this right now. We expect this first series of cost reviews to be completed this year. Some of the first ones hopefully as early as this spring, but that really is kind of where we are in this process at that point. The next thing is, if you identify a drug that's unaffordable, then what does the board do? And that kind of leads us to our authority around upper payment limits. So our legislation basically allows us to set—
for 1 second?
Yes.
And usually I am the last one to ask questions here, because if my members get to it, I don't have to ask a question. But I do want you to go back to those drugs just to give us context and tell us what are they used for.
Absolutely.
Can you do that, please?
Yep.
Thank you.
So the first 4 drugs that we have identified for the cost review study process are all diabetes drugs. Farxiga and Jardiance both fall into a therapeutic class of, they're called SGLT2s. And then Ozempic and Trulicity are also indicated for diabetes, and they are a class called GLP-1. So there are 2 sets of drugs in 2 classes, but all treat diabetes. You may have heard of the GLP-1s, Ozempic and Trulicity, for weight loss. So that's its own kind of topic that I think the committee may be interested in. But for our work, these drugs specifically have the indication for diabetes, so that's how we are studying them as diabetes drugs. For Dupixent and Skyrizi, these drugs are they kind of treat autoimmune diseases, so it's actually a pretty broad list of indications. But yeah, so they treat autoimmune diseases and are often, you can think of those things like different arthritis, different things like that. But both of those have pretty substantial and sometimes very broad lists of different diseases that they treat.
Thank you. I appreciate it.
Yeah. So just going on to our authority for upper payment limits, if you have heard of us, this is probably why. This is definitely one of the hotter button issues that we work on. And so we had to create something called our Upper Payment Limit Action Plan, which actually described what it would mean to set upper payment limits, how we would actually set the amount and how we would actually implement it. And our authority is limited to state and local government. So you can read that as state and local and county correctional facilities, state hospitals, and health clinics. So these are kind of direct purchases made by the state. Any prescription drugs that are paid for through health plans on behalf of state or local government. So you can think of these as employee health plans for public sector employees in the state. And then finally, drugs purchased or paid for by the Maryland State Medical Assistance Program or Medicaid. So it's a pretty substantial list, but all of them are kind of state public entities that we currently have the authority for. So just as an update on our work, this is something that has been a long-term project for our board. The board started addressing the issue of upper payment limits starting kind of in July of 2023, starting to introduce the concept, think of the different ways that it could be implemented. And then there was a series of steps that ultimately got us to our upper payment limit action plan, which was approved by the board in September of 24. It was presented to the Legislative Policy Committee for approval on October 22nd, and the Legislative Policy Committee ultimately did approve the upper payment limit action plan, so that authority is established. And now the next step for us is to publish regulations that actually put that process into place. And we did have a series of drafts that went out for public comment. The board approved the regulations in their November 25th meeting, and the proposed regulations were just published in the January 10th register. So that's the first step. That's the proposed regulations. We're currently in a 30-day comment period, and then the board will ultimately need to approve final regulations that will put this process into place. So that can happen, I guess, as early probably as March is the kind of timeline that the process can be put into place, and then we actually start the process moving forward. Some key takeaways, and here's just the regulations if anyone wants to review and provide comment. Just some high-level ideas. So we did publish the upper payment limit action plan that, again, talked about how we would go about setting an upper payment limit and actually implementing the upper payment limit. And we created a process that we call our policy review process. I think one of the big takeaways here is that the board wants to look at all policies that are available to the state if they identify an affordability challenge, right? So if the board looks at a drug, determines that there's an affordability challenge, either high out-of-pocket cost of patients or high cost of the healthcare system, they want to look at all of the policies that are available to the state. One of those policies is this very specific tool of setting upper payment limits for state and local government, but they're looking at affordability as a statewide issue, right? So they're looking at all Marylanders. They're trying to identify if there's affordability challenges. And then when we look at the policy tools, we are looking at all the policies that would affect all Marylanders, but one of those policies happens to be setting upper payment limits for state and local government. So it's a very kind of specific tool in the toolbox to address a very specific issue. So if the board decides that a drug is unaffordable, we start what we call our policy review process. And the first thing we try to do is just gather more information. They may not have gotten everything they needed out of the cost review process. So we do have kind of different steps and hearings and things like that where we can gather more information and allow folks to address the different findings that the board had as part of the cost review process. Then the staff recommends different policy options. So again, there's the upper payment limit as its own specific policy option, or again, the staff can recommend non-upper payment limit policy options. And as part of this process, we need to identify the drivers that make a prescription drug unaffordable. So like, why do we think this market failure happened? And then the policies should be directly addressing the drivers that we've identified on why a drug may be causing an affordability challenge. And then ultimately, we have a process, and I'll go through this in just a moment, of how we actually go through the policy implementation. And then the final thing that the board will do is either adopt their final determination on the cost review study process, and then they can adopt either non-UPL policy recommendations, or if they set upper payment limits, we would do this through regulations. So there'll be separate regulations that are published for each upper payment limit that the board sets. And this is following like our standard PI or our standard process for policy making. So the reason we do that is there's a proposed rule option for public comment, then it goes as a final rule. So all to say that it's a very robust process that allows for a lot of deliberation and input from stakeholders. So where this fits in our cost review process is this kind of preliminary determination. So the board makes their preliminary determination. If they decide the drug's unaffordable, then they go into the policy review process, and then ultimately there's the final steps there. So Just in a little decision tree. So again, the board has received the analyses from the staff. Then they can make their preliminary determination. If they say that the drug doesn't cause an affordability challenge, that's kind of the end of the process. We just publish a report with the findings saying that this drug does not cause any affordability challenge. If it does, if they do make this preliminary determination, then we go into the process that I just described. So we first identify the drivers, and then the staff recommends policies that address those drivers. And then we have two different kind of processes for upper payment limit processes and then for non-upper payment limit processes or policies. And the reason we did this is because since upper payment limits are within our direct authority, we wanted to have a very deliberative and robust process. So just at a very high level, the staff kind of first gathers information on what an upper payment limit could be. Then we recommend a methodology. The upper payment limit action plan lists about a dozen different ways you can come up with a upper payment limit. So the first thing the staff does is just say that this seems like the methodology we want to use, goes out for public comment. The board ultimately says yes or no or recommends a different policy. Then we actually do the math and then show our work of how you actually come up with the upper payment limit number. That all goes out for public comment. If there's ever any changes based on public comment or board feedback, that goes back out for public comment again. And then ultimately, the board will adopt a final upper payment limit amount through proposed regulations. One of the comments that we got is our upper payment limit plan was very upper payment limit focused, even though we also are thinking about other policies. Again, the reason is because ultimately that is the specific authority that the board has. But again, the board is very much heavily weighing and considering all policies that are available. So that, for that process, basically the staff just, they gathered the information on other policies. We make recommendations on policies based on the drivers identified. The board provides feedback. Staff can update those recommendations and draft potential resolutions. At each of those steps, is public comment and feedback, and then the board will ultimately adopt resolutions for the non-UPL policy options. The other thing that we wanted to just share with the committee is that we do hope to be a resource for you. So I talked through specifically the cost review study process and our policy review process. But again, we are looking at all policies that are available. So we want to be a resource for you. It is an extremely complicated space, and we want to be kind of the impartial synthesizer. We can tell you where each stakeholder group will land on different issues and how things will actually kind of be implemented. So we do want to be a resource for you. We're always available to provide explainers and things like that. We also try to provide patient resources. So if you have constituents that are coming to you saying that they can't afford their drugs, we are a resource for them. You can refer them directly to us, and we call it our patient navigator program, walk them through all the resources that are already available to help them afford their drugs just within the current system as we work on these kind of longer term, bigger picture policies to make drugs more affordable. I guess the last thing is we've received questions from different committees just in terms of the expansion of our authority. So right now we have the authority for state and local government. Our legislation also contemplates the expansion of our authority. The staff is ultimately working on a report that addresses some of the issues and concerns on that per our statute. And we don't have any specific timelines on that, but the board is available to answer any questions that you may have. So with that, happy to answer any questions that the committee has.
I want to first start by saying thank you for all your efforts, not just by being here today, but every time we email you for information, for research, you're always available. So I want to thank you on behalf of the committee. I'm going to open it up for questions now. I see Delegate Hill, followed by Vice Chair Collison.
Madam Chair, thank you for your work and for being here today. If we go back to the slide of the medications that were chosen, and we go back to the original of authorizing legislation, there were a number of criteria that could be used to choose the drugs to look at, including a drug that's been out for a while that has more than a 200% increase in price in a short period of time. Can you go through those drugs and explain why they were chosen? And of the various criteria, there are criteria where there's nothing from those categories. Can you address that, why we're not seeing some of those other categories?
Yes. So the drugs that are eligible became eligible through both statute. So the statute says name brand drugs that have an annual WAC of more than $30,000, or name brand drugs that have undergone a WAC increase of $3,000. Biosimilars that are not at least 15% less, have a WAC that's at least 15% less than their name brand reference product. And then generic drugs that are over $100 per month and go up over $200 per year. So that's kind of what the statute made eligible. And then the board and then there's a final criteria that says, and also anything else that the board adds. So the board passed regulations that created a number of other different criteria that they were looking at. Things like highest out-of-pocket cost per patient, and then highest out-of-pocket cost overall, highest gross spend, so that's like what the payer and the patient spend, and then per patient, and then highest overall. So just a number of different criteria. And what they received was a dashboard that basically had all the eligible drugs and then columns for each of the different criteria that they could consider. And what the board ultimately decided to do was allow each board member to go through those and use their own priorities and criteria to identify the drugs that they found most interesting, I would say. And then each of those board members submitted their list of drugs that they were considering to the board chair, and the board chair ultimately published that list publicly. There's a couple different ways you can do that. So if you think of how the Medicare negotiations work, they have very specific criteria in terms of they look at the highest overall spend to the Medicare program, and then they have a bunch of exceptions. It has to be on the market for some period of time, those kinds of things. Other boards have on the front end said we want to prioritize drugs that have the highest gross spend or have the highest per patient out-of-pocket cost. As part of our discussion, or the board's discussion, they ultimately said that they want to be able to keep all the different scenarios on the table. They didn't want to, on the front end, say we're only looking at high volume, high cost of healthcare system, because then they wouldn't get to look at drugs that don't have that many patients but maybe very high cost. So the way that they've managed it is through this process of nominating drugs for their own criteria, like based on their own review, submitting it to the chair, and then that all goes before the public and then also the stakeholder council for input. So I think for each drug, I would say they're all generally very high spend to the state as a whole, generally high out-of-pocket costs for patients, but there were no specific rules that they were following when they picked that initial list of drugs.
Thank you. And it's not part of the data you presented. Are those 6 drugs spread across different manufacturers, or is there a manufacturer that has multiple representations on that list?
So each of these have different manufacturers. I think one drug has like a partnership with manufacturers, so there may be one manufacturer that shows up twice through kind of like a collaboration, but they're all from different manufacturers. I don't think that is necessarily something that the board was looking at. I think that might have just been coincidence as much as anything else. Yeah. Yeah.
Thank you, and thank you for your patience as you answer these questions. I have Vice Chair Collison, followed by Delegate Shalega, then Delegate Bagnall.
Thank you, Madam Chair, and thank you, Andy, for presenting today and for getting us to this place. The process includes public comment. How many different times from the time a drug might be identified in that original long list to when the decision is made about whether or not an upper payment limit is the best policy or one of those other things is the best policy? How many times is there public comment in that process?
To the frustration of my staff and probably the members of the committee, it is different for each process. So for the cost review, there's the initial selection, like basically publishing a list of drugs that the board is interested in. There's a public comment process there. Also goes before the stakeholder council. We consider them kind of like the expert public as they provide their own input. Then once that feedback is public, the public can provide more input before it goes to the board meeting. I guess one thing I should also say is for every board meeting that we also invite public input. So at every single board meeting, you get to add that as a potential opportunity for public input. Then there's the RFI process itself, which has so once the drugs are selected, we do our request for information. There's an opportunity for public input at that point. When we publish the drugs, I think it's a 60-day comment period there. We also specifically reach out to different stakeholders for public input there. Again, there's so our board is about to start actually conducting the analysis of affordability. So for each of those, we'll be publishing materials. Folks can provide comment on the materials themselves for the board meetings. Then once so that gets us to the board making their preliminary determination, which again is not even a final determination. They're just based on the data that they have. This is their preliminary determination. So that gets us, that's probably, I don't know, 5 or 6. We do have a list. I can tell you the actual numbers for each part. Then once the drug is deemed to be causes potentially once we make a preliminary determination on an affordability challenge, that then opens up a series of hearings, public comment, other options just before we even get to the point of deciding if an upper payment limit is correct policy. If the staff recommends that an upper payment limit is the correct policy, there is a public comment period on that. The board staff will say, we believe that upper payment limit is inappropriate in this circumstance. Here's the methodology we recommend. Once that happens, then there's additional public comment. Then we actually publish the number itself, the calculated upper payment limit based on all the feedback that we received. There is public comment on that. If there are any changes to that number, there's another set of public comments. So I would, just off the back of my hand, probably about a dozen times. But again, it is, I think there's a balance of also making sure that it's clear that these are the opportunities to provide public comment.
Just to clarify for the committee, so there's this stakeholder group, which is about 36 people
26,
representing all parts of the drug pricing chain, right? And public includes all of the elements in the drug pricing chain. You receive comments from pharma, from pharmacy benefit managers, from wholesalers, from pharmacists. They're all part of that public outreach on this process. Is that correct?
That's correct.
Thank you, Andy.
Yes.
Appreciate it.
And I'll provide a written response with the actual concrete number of public comments.
You could send it to the entire committee.
Yes.
Thank you. We share here.
Yeah.
Delegate Shalega, followed by Bagnall.
Thank you, Madam Chair. Thank you for being here, Andy. The presentation was great. What I gleaned is there have been no upper payment limit. Anything has been set yet, but you're saying in May, you think May, June, we'll see something?
The board can begin the process probably as early as this spring, but ultimately the board is not saying that they'll set upper payment limits. They may just choose that upper payment limits are not the right tool, but the process will be established as early as this spring.
So if there were any, when would they, I guess that was my question, if there were to be some upper payment limits set, when would that happen?
So you saw how extensive the process is.
Yeah.
The process can probably start. It looks like our regulations. So regulations were published on June 10th or January 10th, 30-day comment period. If there are no changes, then we publish. So that puts us kind of in the March timeframe where the process can start. But that's, as you saw, a very deliberative process with multiple steps. So it's hard to put an exact timeline on when an upper payment would be set. Spring or summer is like fastest case scenario, but I would expect it to take a substantial period of time just with all the opportunities for public comment.
End of year, can you spitball it or is it too hard?
Middle to the end of the year, I think is as fast as it could happen. If you've seen the timeline that I presented, we are very deliberate and take our time in our process. So the fastest that it would be able to happen is sometime this year, probably mid to late this year.
May I have one more? Thank you. So I appreciate the presentation, and I know what the upper policy UPL is, and we've discussed this at length, but I don't remember hearing about a non-upper limit payment limit policy. Is that new? Do you need a bill to do that? Is that going to by regulation, and what does that look like?
So our specific authority is the upper payment limit. So a lot of our proposed changes would be either with our executive branch partners or recommendations for legislation. So some of the policies that may be interesting are things like around plan design, different patient protections. What we hear a lot from different folks that are in this conversation is, sometimes the out-of-pocket cost isn't directly related to the manufacturer's price, so those are plan design issues. So you can look at policies around plan design, you can look at other patient protections. So it would probably be recommended legislation, potentially regulations coming out of other executive branch entities.
So this year, you're going to have legislation for this non-UPL or?
It would come out of the policy review process. So if we're doing the policy review process from, May to like the middle of the year, it would probably be something that would be for the 26th session.
Thank you.
Yep. However, we're always happy to help with policies that you're considering. So if you have policy or legislation you wanted to send to us, we're happy to analyze it and provide, feedback on that.
Thank you.
Yeah.
I have Delegate Bagnall, followed by Delegate Chisholm.
Thank you, Madam Chair, and thank you.
You're welcome.
Thank you for your presentation and for walking us through this very deliberative process. And I think mine is a follow-on question to my colleague, which is just understanding the upper payment limit policy proposed regulation versus the non-upper payment limit policy resolutions. Just for the clarity of this committee, those are not mutually exclusive. Is that correct? Like this is as you're doing this deliberative process, you could, if you identify best practices that would make sense through a non-UPL process, they can work simultaneously. Is that correct?
That's correct. So the exercise that we go through for the policy review process is we're saying there was this market failure or some challenge within the supply chain that is making this drug unaffordable to patients or the healthcare system. So we identify what that driver is. And again, there's different circumstances in different cases. That's why we have to look at each drug. But then we recommend the policies that the state can apply. So one may be this upper payment limits for state and local government, but then it may be in addition, like plan design issues or patient protections. We always refer back to the bill that the General Assembly passed on creating copay caps for insulin, right? That's something that addressed an affordability challenge around insulin. So those are the kinds of things that the board would look at when they're looking at other policies.
And if I could just follow up, and just to further clarify, this isn't like we must exhaust all non-UPL options before we look at a regulation. Is that correct?
Correct. It's based on the experience and expertise of the board and the stakeholder council and the analysis and the information that is provided. Here is the buckets of policies that will address the affordability challenges for this specific drug. So it's not saying that we have to exhaust every policy option. It's like based on the very specific circumstances of this drug, here's how we think this will be affordable to Maryland patients in the Maryland healthcare system.
Thank you very much. Thank you, Madam Chair.
You're welcome. I have the following: Delegate Chisholm, followed by Hutchinson, followed by Taveras.
Thank you, Madam Chair.
My
You're going to think we coordinated this because it was the first thing I took from the key takeaways. There are a number of different policies available to the states to address the different market failures that may cause affordability challenges. Obviously, you guys are starting to look at this. Would it be helpful to make some recommendations to this committee to say, this is what we see happening? This is what we see as successful legislation in other states because they're obviously doing it because you're looking at it instead of us guessing all the time, okay, what should we do? I mean, the whole point of the PDAP was to bring prices down, and I know you guys are working hard, but we're 7 years in now and we're still studying things to figure out, okay, how do we do this? Obviously, there's a track record of success that you're alluding to in your key takeaways. Can we get an idea of what legislation may be able to get us to the point that we start to bring some of these drug prices down rather than continuing to guess, okay, what do we do?
It's a great question, and I think that is a priority for the board. In the middle of 24, this is something we brought before the board, and just based on the limited resources of the staff, the board decided to table any recommendations for 2024, but it is something that the board is talking about as early as this year. So the way it would probably look is, a lot of these, and you get these pieces of legislation before your committee all the time, but a lot of times you can have policies that kind of pull in one way and push in the other and don't necessarily all pull in the same direction or address a specific challenge. You have a specific stakeholder that says this is a challenge, but you need to balance that against the other potential policies that kind of push and pull against that. So the board is hopefully early this year going to kind of pick different, you almost need to like pick a whole section to kind of analyze and come up with a series of policies. One example is, for example, PBM reform. So that's happening at the federal level, but there's some state things that the states can do, but there's probably a dozen individual PBM policies you can have. I think what you want from the board is the state should pass this portfolio of PBM policies that are all kind of pushing in the same direction and trying to make the same market changes. And I don't mean to pick on PBMs, but that's just like what the feds are working on at this point.
We like to do that here.
But all to say that I would picture like a theme for our annual report that does a deep dive on specific issues and then comes out with a series of recommendations. It's very resource intensive, and I would picture us to have kind of a series of information gathering and collaboration with our stakeholder council. So that's probably a 6 to 12 month process. So it's probably something I can't make promises, but something that the board would hopefully be able to put in their annual report of 2025 that would have specific policy recommendations. Some of the things that they've discussed in previous reports without formal recommendations is transparency bills. So trying to address that kind of backroom deal element, and the fact that one of the findings from our work up to this point is we're 7 years in and we still can't tell you the specific cost of a drug, the net cost of a drug. It's just not available to us or you or anyone else really. We also are trying to, there was some discussion around trying to make more competitive markets in the biosimilar space. So there's a lot of just technical restrictions in that space. So there's a lot of opportunities for states to do some work there. So it's just that I would say lack of resources at this point. It's a very small team, but in the future we would hope to have kind of a series of policy recommendations to the legislators, kind of pulling all in the same direction.
Perfect. Thank you. Thank you, Madam Chair.
Thank you. And I have Delegate Hutchinson, followed by Taveras.
Thank you, Madam Chair. Andy, thanks for being here. Every time we talk, I learn a little bit more. So, but I still have some confusion. I just need a little bit of clarity. So you say that there will be savings for all of Marylanders with an upper limit. So does that mean, is that the consumer that goes to the counter to pay for their drug? Is that the state plan? Is that the payer? I just want some clarity on who is actually getting the savings.
One of the challenges we have is this distinction where our cost review study process is looking at affordability to the entire state. And the policy recommendations we will make may apply to the full state. One of the policies we have is this very specific tool that works for state and local government. So if we were setting upper payment limits for state and local government, that doesn't necessarily translate to savings for all Marylanders. But the other policies that we may recommend, the non-UPL policies, we do see the scope as working for the full state. So I wouldn't expect any specific savings to non-state employees based on upper payment limits, but the other policies that we're recommending or potentially the board can recommend would hopefully provide savings to the full state. I know, very complicated issue, but like all of our work is looking at trying to make drugs affordable for all Marylanders. One of the tools that we have in this toolbox is setting upper payment limits for state and local government, which will save taxpayer dollars, right? That's like one tool in the toolbox, but we're looking at all the tools, and the other tools have a much broader scope.
Boy, I can't wait. I can't wait to talk to you offline about that a little more.
Yeah.
Thank you.
Yep.
I have Delegate Taveras.
Thank you, Madam Chair. I just want to say thank you for this presentation. I mean, I've only been here a short time, and there's been a lot done on this. So I would consider that as you look at all the drivers, maybe doing some trend analysis, particularly to see was how this, how these prices change or whatnot. But as you just said, right now there's no rhyme or reason. But my question is, what are you have in the appendix contextual information? This is very informative. So are all these items analyzed in the making of a decision? Because it seems like this is a lot of data that you have listed. So in that making of that, making that determination, you look at all of this in addition to the drivers.
So thank you for reviewing the extra materials. We included the appendix because this is kind of the most hot button issue. But going through the entire upper payment limit process is a full hour, if not more, presentation. So we just included those as extra materials. So you're correct that these are things that the board will be able to consider in the setting of an upper payment limit. So these are different data points and data that they would want to look at and consider in the process of setting an upper payment limit. This is separate from if they determine if the drug is unaffordable. So there's kind of a separate list of things that they'll look at there. But if they've made their determination that we've done the cost review study, we've made a preliminary determination based on everything that we've seen, it looks like there's an affordability challenge, then there's this process. And as they're going about setting the upper payment limit, these are the different elements that you would want to look at when you're setting the upper payment limit. So I agree. As you can see in a lot of our processes, they were over-inclusive in terms of public comment, and then also with a lot of researchers on our board, more data is better, right? So I think we are often try to be comprehensive in the different things that the board would want to consider as they do their work.
Thank you.
Yep.
Thank you, Madam Chair. And because it's a briefing and there's just information to be shared, I appreciate your graciousness. Thank you. I wanted to follow up on your response to Delegate Hutchinson's question. You all have done the studies. I think when I know that when we put the upper payment limit in and we talked about doing it for those plans over which we have control, we also know historically that when upper payment limits are in, so with Medicare payment and reimbursement to providers, for instance, that when insurance companies find that products are able to be sold for a lesser price, there's a fight to the bottom. So that for providers, again, as an example, if Medicare only reimburses at a certain rate, the insurers then say, since you're willing to take a Medicare at that rate, we don't have to pay you as much as we used to. We're going to pay you less too. So you've looked at the studies. Do you have a comment about that? Because yes, you can't predict that it'll affect all patients in Maryland, but there is an expectation that it may because of those kinds of forces. And secondly, you've looked at the others. We were the first. We have a very deliberative process. Have any of the other affordability boards that started after us actually put into practice upper payment limits or any other strategies to affect that?
So to the first question of how this could impact the broader market, we do think that there will be one of the issues that will come up is this transparency issue that I had mentioned before. In that, sometimes sunlight is the best disinfectant. And one of the challenges we see in this space is this very large difference between the gross cost and the net cost. And a lot of our work is going to be based on the net cost. So I will just say that I think is going to be an interesting part of the work. It's going to look similar to what Medicare has done with their maximum fair price. That also, I think, tries to get to a reflection of the actual cost of the drug versus just the inflated gross spend of the drug. We do have a number. The way that we've designed the upper payment limit to work for state and local government is that since it is a very specific segment of the market, it's meant to not affect the existing transactions. It's ultimately like what we're looking at is the final step or cost to the plan. So I think there's a number of protections in there, or not even protections, but just in terms of implementation, the supply chain will not be affected the way that we're doing it. So in terms of if there's overflow in that space, we don't see that as a risk. The last question was if there have been other upper payment limits set. I would say that Colorado is closest to where we are. They've, I think, done 5, they call theirs affordability reviews. I think they've deemed maybe 3 drugs to be cause affordability challenges. So they're now at the process of setting upper payment limits. So they have not finished that process yet. I think they're in the rulemaking. So kind of in a similar place to where we are. But we do kind of look to other models as to provide frameworks, and we often look to what Medicare has done. And we think it's a comparable process to what we're looking at.
Thank you. Thank you, Madam Chair.
Bandari.
Thank you, Madam Chair. Thank you for your excellent presentation. And what enforcement mechanisms are in place to ensure the compliance side from manufacturer, pharmacy, benefit manager, and other entities in providing data or adhering to the UPLs? What penalties exist for non-compliance?
I'd say there's no penalties in the statutes. Some statutes do put specific penalties in. Our enforcement authority comes through the Office of the Attorney General. Our statute references the Office of the Attorney General. So that's kind of an outstanding issue, but all of our work will be done through regulation. So it has the same kind of effect or legal effect as any regulation that the state would publish.
Do you think we have to introduce any bill?
Sorry, an appeal?
Is it needed any bill for the...
A bill for authority? We think that it will function as it is, but ultimately we have to go through the process and try to implement it. But we expect, I mentioned frameworks that we look at. The way that we're thinking about implementing it for state and local government is something that's already happening for New York and Massachusetts Medicaid, and they've been very successful with their program. So we believe that the way that it's being implemented will successfully occur. I guess in 2026, we may come back to you and say this didn't work, and then we may have specific recommendations on a bill if it doesn't work the way we think it will. So.
Thank you.
Yep.
Questions? I don't see any other questions. I want to just take a minute to thank you for your work. I know it's a long process, but what I respect is the fact that you're really taking your time. We're the first in the nation, right? The bill passed in 2019, then it was vetoed, the funding in 2020, then we had to do a veto override in 2021. So you're really doing the work since, let's say, 22, 23, and now 24 for the last less than 3 years. And I know you want to get it right. And I am really grateful that you have the whole supply chain, involved and to give you comments. Thank you for all the efforts that you're doing and you're putting into getting this right. Because at the end of the day, the reason why this committee, the whole committee, supports this is because there are many people that are trying to make decisions every month between whether they can buy their groceries or pay for their drugs. I get calls from seniors who 2 months ago, one medication is $1,500. And what I did was I called the company and found out that they have those cards that you can sign up, right? Watch a little video for a minute or two, and then they give you this discount card. And this senior was so grateful because she could not afford it otherwise. And we just need to find a way to do this right. So the committee is willing and able to work with you when you decide on all these other policies. And I love the questions that Delegate Chisholm asked you, that you think that we should contact any of us to put these bills forward, because all our constituents, regardless of where we come from, care about this issue very much. So thank you so much for your time and all your efforts. I don't see any other questions here, and I just want to thank you on behalf of the committee. And you're the only witness for this topic. And guess what, committee? It is 1:55, so 35 minutes early. So I want to thank you so much for coming, and you have a blessed day. I do want to tell the committee that we do have a briefing, and I believe we have the briefing scheduled for 2:30?
It's bill hearing.
I'm sorry, bill hearings for 2:30, right?
No,
For 2 o'clock. So guess what? You have 5 minutes. I'm going to give you 10 minutes. To 2:05, go get something to eat in the back. 2:10 on time. 2:05 on time, okay? 2:05. Thank you.